Hello, everybody, and welcome to another episode of Meet the Greek podcast here at the Fred Hutch Cancer Center. I'm always very pleased to learn from amazing colleagues and showcase the talent we have here at Fred Hutch. And today is my distinct honor and pleasure to introduce to you and hear from a dear colleague, an amazing leader here in the field, Professor Dr. Brittany Barber, who's an associate professor. She's also serving as the division director of head and neck surgical oncology, and also the division, I think, in addition to that, Brittany, I think you're also heading the fellowship program.
Yeah, thank you. We have a large team here, and so I'm happy to be part of them.
Amazing team, no doubt. And I have to share with you, Brittany, that I think the first podcast Meet the Greek was with Dr. Rodriguez. So we did start with head and neck. So it's amazing to see that progress and the team expanding, and there's so much to cover in a short amount of time. But I will start, Brittany, with your journey so far. I hear, about you. Dr. Barber is doing great things. Tell us about how the journey started, and you're here in Seattle.
Thank you. Well, it's I think it's a nice tale. I've just been very lucky to have done a lot of my training in Canada, but I knew about a surgeon that had trained one of the surgeons that trained me in residency, and I wanted to work with him. And so I did some training in New York after finishing my residency in Canada with somebody that he had trained, and then was just very fortunate that a job came up. I had been kind of keeping in contact with the team here for many years. I came here as a resident even before I ever interviewed for a job, and then was very lucky and managed to get my dream job here. And I've been here ever since. And it's been a wonderful 8 years. Yeah.
And I think, if I remember correctly, you and me came about the same time, about 8 years ago. Time flies, isn't it?
That's right. Yeah, it's. I still feel like it's. It hasn't been forever, but it also feels like forever at the same time.
I'm sure it's very, very busy, expanding the program, being the fellowship director, serving the educational mission, of course, taking care of patients, doing research. There is no free moment. So I'm going to start asking you, Dr. Barber, about all those elements. So I will start with patient care, and I know this is a dear passion of yours. Tell us about, things that come to mind when you take care of patients in clinic. It's a patient population with major needs.
Yeah, so head and neck cancer patients it's tough. It's a tough diagnosis. It's something that affects all of the things that make us human. So communication, eating, being social, the way we look. And so for that reason, the first time I ever treated a head and neck cancer patient many, many years ago, I knew that was what I wanted to do for my whole life. It was one of the first surgeries I ever saw, and I knew I had to do it. It's one of the best things about being a head and neck surgeon is that it's a team sport. So a little bit like my old days where I used to play hockey, it's the same. There's a team that's involved, and the team works together. And then that's in the OR. Outside the OR, there's another team. There's the multidisciplinary team, the medical oncologists, the radiation oncologists, the speech and language pathologists, the dietitians, the dental oncologists. Just the whole team is involved. And that's the way cancer care should be delivered. That's why I've stayed at Fred Hutch for as long as I have, because that's the right way to treat patients. It should be a team approach. And we have the best team.
I totally agree with you. And I think the strength of the wolf is in the pack. And that's exactly right when it comes to head and neck oncology and beyond. Across oncology spectrum, these different specialties coming together, delivering the best care, the tumor boards we have, right? All of the above.
Yeah. Yeah, we're very fortunate to have a really great team here, and a team that's collegial, a team that always gets along, that's always aligned. And that's not the case everywhere, but here it's always been like that as long as I've been here. So it makes it easy to treat patients because we always are a unified front, and it always makes it easy to treat patients because they're our friends. They're like our family. We work with them so much. So it's been a pleasure these years.
Absolutely. And, I always say, when you have fun, with your team, the colleagues, the team dynamics makes the work much more pleasant. And I think the output, the delivery, it's even better, right? And I think patients see that. Patients and their families, their caregivers can sense, the team dynamics and the wonderful team we have here at Ferhats. And, in that context, I am always intrigued in a good way and impressed with how great work you're doing in the head and neck oncology um, domain, because there are so many different cancer types, right? Nasopharyngeal and tonsillar and in tongue and base of mouth and of course laryngeal and so on and so forth. How do you think that multitude of cancer types from the surgical standpoint, because the different operations involved or no operations? It sounds hard, but you guys have it down.
Thank you. Yeah, one of the reasons I chose this field is because we kind of get to own an area. With the most important thing in that area is just knowing the anatomy and being familiar with that anatomy and seeing it day in and day out throughout your training and then for years afterwards. And so it makes it so that there isn't much you haven't seen after a while because you spend all your time in that area. It's not nothing is no anatomy is new. Everything is always what you're expecting. There's certainly things that come up that are unusual, but you have a framework for dealing with it. And so that means that when there are different tumors that come up, I mean, there's quite a few different types of pathology, types of cancers in the head and neck. But that's one, being familiar with the anatomy helps. And then in addition, just having a team, that's part of the team. And there are people that have a little bit more insight about some cancers than others, and that's why having a team helps with that. It also helps that, the areas in the head and neck are kind of confined to one space, and so it makes it so that those are all areas that we're always working in.
Absolutely. And I know, I always learn from you guys. And I was talking to Dr. Rodriguez the other day, and there's so many different risk factors, of course, of head and neck cancers. Smoking, of course, is a big one, alcohol use, HPV, human papillomavirus, especially for, if I remember, posterior part of the tongue, tonsillar, and pharyngeal cancer. So huge improvement with vaccination against HPV. Any comments on that front?
I think that we have yet to see all of the benefits that vaccination can bring to this type of cancer, for that specific type of cancer, but the incidence is still going up and it's projected to continue to increase until around 2040. I don't, unfortunately, I don't think that we'll have quite cured that one just yet, but vaccination is absolutely important and it does make a difference, of course, if it's implemented at the right time. Um, if you'll permit me, one of the things that's a little bit interesting about head neck cancer is that there's another type of cancer that's on the rise that doesn't have an etiology. We don't know why it's happening. And a lot of people attribute it to HPV, and that kind of misinformation can be a bit damaging. So we're seeing a lot of cancers in the lateral part of the tongue, the anterior part of the tongue, in young non-smoking women, Caucasian women. And we don't know why, and we don't have an etiology. We don't know why it's happening. But there needs to be more study on it, and so that's an interest of mine. There's often some misinformation about whether that's related to HPV or not, and it's not. It's been shown many times that it's not. So it's a not relatively unexplored, I wouldn't say unexplored, but underexplored area of our specialty that has emerged over the past kind of 10 to 15 years.
That's very interesting and, definitely draws attention why this is happening because the factors, potential prevention, but it sounds based on what you're saying, Brittany, not related to HPV, lateral and anterior part of the tongue. Interesting.
There have been, a couple different etiologies proposed. Lots of people think that it is mirroring the early onset colorectal cancer pandemic. And so it could be diet related, could be exposure related, could be toxin related. Not sure yet. I'm sure that the next kind of decade will bring us more answers.
For sure. And there's, as you said, in pandemic, of young cases in oncology, and always, blows our minds why this is happening. And to your point, there are multiple potential causative factors, although we're not clear yet why this is happening. And a lot of discussion about the microbiome and is there a role with colorectal cancer and diet, exposure, toxins. It's hard to tell. So research is needed, but to the maximum degree, avoiding known risk factors. Alcohol, smoking, of course, is important. HPV vaccination is important, as we discussed, and of course, research, right, to set line into this. And talking about research, I know you're so active in that domain, Brittany. Tell us a little bit more about your research and what excites you.
I feel very fortunate, again, to have yet another team that I get to work with on research. And so a couple different areas that interest me, but one of them is the quote unquote kind of young tongue cancer pandemic that is occurring globally. And so for some of those studies, I've worked with Dr. Holly Harris and Dr. Amanda Phipps, who are epidemiologists that work at both the Hutch and the UW. And a lot of the studies that we've done together have been on different exposures that can cause this oral cavity cancer pandemic. And then, in addition, looking specifically at about what's happening globally with that cancer, with these early onset cases. So some of the studies that we've done recently looking at epidemiology have shown that, interestingly, young female cases seem to be rising mostly in high-income countries, whereas young male oral cavity cancers seem to be increasing mostly in Central America. And why that is, it's hard to say. Unfortunately, we're not able to look at tobacco-related cancers on a global scale, but it certainly is thought-provoking and hypothesis generating. Um, in addition, I've done some work with Holly Harris looking at diet and specific diet components and how they can relate to oral cavity cancer risk. And so one of the studies that we did the last couple of years was looking at how sugary beverages can influence risk, particularly in women. And to put things on sort of a scale, the risk with high sugar beverage intake for women and oral cavity cancer is a little bit close to what it is for tobacco. So it's a pretty bad risk factor and certainly worth more study. Certainly made me give up my coffee creamer in the morning. um, and then in addition, we kind of looked at diet as a whole recently and found that it seems to be more impactful for risk for women. So a poor diet was given about a 2 times increased risk of oral cavity cancer in women specifically. So it seems as though it's pointing toward, women having very impactful choices to make when it comes to their diet and their risk of oral cavity cancer.
Very exciting, and thank you for outlining those domains so eloquently, Brittany. I think there's so much to do in the field, and so many questions. I always, tell mentees and trainees, oncology is exploding in terms of our ability to ask questions. Number one, and then try to answer them. Number two, and there are always more questions. So there's definitely more work to be done. And I'm glad you mentioned all these amazing colleagues. I had the chance to work in the past with Amanda and Meredith. Amazing, and it brings it. What I when I first came around the same time with you, I was telling friends and colleagues, I feel like being in a candy store with amazing talent. I want to work with everybody here, and that's right. The exact same experience with you.
Yeah, that's exactly how I describe it to people because I have to say that what we have here at UW at Fred Hutch is a very unique environment. It's a very collaborative environment, uniquely collaborative. And people will say that about other institutions, but I think the give a care factor here is just very high. It's high in patient care, it's high in research, it's high in team dynamics, and so it makes it so that people are always willing to pitch in and answer that question and help out in some way. And it's rare that somebody will say no. I've yet to hear that in my time here. So it means that you're busy, but it means that the opportunities to change the field, to influence care, are numerous. And so, one of the best things about this institution, for sure.
Very well said, Brenda. I feel the same way. It's so much opportunity to make a positive difference, right? By have team of experts to your point. And the other aspect of that is education and training, and you're serving as a fellowship director. So much opportunity to give the chance to the younger generation or next generation to do even greater things. Tell us about that role you have and how great it is.
Yeah, thank you so much. So I'm now sharing this role. I've been in this role for a couple of years. I'm now sharing it actually with my other colleague, Dr. Emily Marciano, and so we'll be doing that for a year, and then she'll take over. I've just really enjoyed my time doing it because the people that we train, they go off and they go in the world and they do great work. They help patients, they teach, and they change the field after you. And so it makes it feel like long after you're done with your career, people will continue on doing great work. And just like I have taken many lessons with me from many of my mentors. So it's been a wonderful opportunity to mentor people. It's been a wonderful opportunity to keep me on my toes always. People ask questions. You have to switch things up, learn things new to keep people interested. And then also a fantastic way for us to showcase what we have here. The special team that we have here, the cancer care, the patients, and the training environment. So, yeah, it's been fantastic. I've had I guess 8 fellows now. God, 8 fellows on my ninth fellow, and they've all gone on to do really fantastic things. I get to see them at conferences, and they get to tell me about tough cases they've had, how they handled them, and I couldn't be prouder every time. So it's been fantastic.
So
Yeah.
inspiring and rewarding, right? And
Yeah, yeah.
you see them grow and you see them in conference presenting and they do great things. You interact with them. I always tell my mentees I learn from them, and it keeps it definitely on my toes in a good way. I try to, right, deliver quality, exactly what you're saying. And, the other big aspect of what we do, Brittany, is the interaction with colleagues and colleagues, of course, internal and external. And I always really, really inspired by colleagues in community. They see so many different cancer types in medical oncology, for example, and other disciplines. And I always ask them, how can you do that? It's diverse. So, and the answer is, we need each other. And they say, oh, we need you, Petros, for your expertise in urinary cancers. We need, Dr. Barber for expertise in head and neck malignancies. So I think it's a mutual, wonderful relationship. Tell us more about that, how it works on your end in the highly specialized care we provide here for HATS, how we interact with colleagues in community, surgical colleagues and others in the broader community.
The kind of collaboration that we have here at Fred Hutch and UW, it really does extend to our community colleagues. It's just the Pacific Northwest is a wonderful place to be because people tend to be collaborative and want to pitch in. And so I would say that that's certainly the case with our community colleagues, both inside the Fred Hutch family, UW family, and outside. I mean, people want their patients to do well. And I think that people will, the way it typically works, people will call us, they'll say, hey, what do you think of this? Is this operative or is this better for chemoradiation? Or, hey, what would you guys do here? Do you think this needs reconstruction? And, we'll take a look at it. We'll present the patient at tumor board even. We'll take a look at pictures. We'll take a look at scans, call them back and say, hey, I actually think we can save this guy a trip down here. I think, he's best treated in your hands. Chemoradiation back home in Bellingham, for example. Or, no, I think that we can do erotic surgery for this. I think that they would benefit. We can de-escalate their care a bit and, we'll save them radiation to one of the necks. And so that sort of relationship is really important because it just means that patients, when they need to see us, they come down to us. And when they're going to benefit from our care, they come down to us. But when they can easily be treated at home, then that works too. So that's kind of a typical example. Lots of times it's kind of transferring patients in from the 4 corners of the 5 states and saying, we're going to get them here, do everything in one case and then send them back and continue to see them for surveillance as we can, as they can make it here, keep in contact with their local teams, tell them, make sure that scans are being done, look at those scans from afar. I mean, we have lots of ways to deliver care and we have to be facile in this kind of very large 29% of the US landmass region that we serve. So,
Absolutely. And you mentioned it so well, Brittany. There is so much space in that part of the country that, and many underserved areas and populations that people live far away from a cancer center and live far away from expertise like yours. So that communication, bi-directional communication between us and our colleagues and friends and community is so vital. And I think patients love that. When we pick up the phone, we talk to the community colleagues and we have this symbiotic, collaborative relationship for sure. I think it's serving the needs of the patients. And we have a diverse population. We have people who live in Alaska or Hawaii or, WAMU area here. Definitely all of them need our expertise. And it's also relevant to your research. You mentioned before these trends epidemiologically, and this diversity of population may also help that research, right?
absolutely. And I think that it also inspires us to make sure that we're tracking a lot of the patients that we take care of because we serve this very diverse population. It means that it is because we serve a very diverse population, a very large population, it means we see those 1 in 1,000 cases like every Tuesday. We're used to seeing them because of the breadth of pathology that 29% of the landmass of the US can give us. And so it inspires us to look into these things, to research them, these rare histopathologies, and to open trials for them. One of our colleagues, Taran Gujral, studies rare cancers. He's done amazing things pushing that field forward. And so, again, I think that probably is born of being in a place like this where rare cancers walk through the door every day. So.
Absolutely. And different environmental risk factors, sometimes genetic factors and germline mutations may come to play. It's definitely important to have this multidisciplinary approach, genetic counselors, nutritionists, as you mentioned before. And, through all of those different aspects of what you're doing every day, becomes also a question, how do you do everything? So efficiency, it's always impressive, right? How many things we do. Tell us about how you make it happen.
Well, I could say there's one very shining, there's one very good reason why I can do it all, and then there's lots of other small reasons. One very big reason is our team, our nursing team, our support team. They're second to none. Just as long as I've been here, I've had them, and they're just fantastic. They make all the difference. We couldn't do any of it without them. So that's one very big reason, no doubt about that. And then our wonderful support and trainees here at the UW and at the Hutch. I mean, that is another really big reason. That's how we can do those things. And then in addition, I think I think, and I may be wrong, but I think that people don't work at an institution like this without a healthy level of professional curiosity, a question that drives them to work early mornings and late hours. So I think that I'm not alone in that by any means, and there are lots of other people that do that. So, including many of my colleagues. So I'm certainly driven by the other people around me that run at that pace, I would say. And then I think at the end of it all, the thing that probably drives all of us is patients come in and they have a problem and you want to fix it for them. And then if you see that problem enough, you want to figure out how to not see that problem anymore and how to stop that problem from happening. So I think that's the point in my career that I'm at, is that I want to fix that problem and not have to, um, not have to have those heartbreaking conversations anymore.
Absolutely. And so well said. I think, you did a great job, putting together the exceptional patient care and the research, right? And how these two things are intertwined. They come together. And I always tell people they're not polarities. They're one thing, and the patient in front of you asking questions triggers a great research program that you can ask in the laboratory or in the clinic, epidemiological research. It's so, important to have the stimulation, inspiration from patients to do our research. And I think it goes back and forth. And the other big question, for you, Brittany, you have at least two leadership roles right now. I'm sure you will have many more in the future. Tell me a little bit more about how you think about leadership, in terms of your division and the fellowship program.
Yeah, thank you. Well, I sort of see leadership as a service role, and so not telling people what to do, but rather people telling me what they need. So I'm probably early in the leadership game. There are many levels above me, and I have been really fortunate to learn from many mentors over the time that I've been here, how to do things, how not to do things, how to fix things you've done, how to make things better. So I've been really fortunate. Several of them come to mind, so you know who you are. And I've also been really fortunate to see that in other parts of our multidisciplinary team leadership that styles that work there. So I'm learning more about this role, but I see leadership as a service role, as you know, what do I need to do to elevate the entire program, to elevate the care we provide, to elevate the research we do and the education we provide? How can I make that happen? And it's often people telling me things, problems that need to be solved, problems that things that could be better. And so that's how I see it. Maybe it'll change over time, but that's also how I've seen other people be successful leaders. And I hope that in all that, I remain inspired and inspire others, hopefully.
So well said. I'm glad we're doing this podcast recording so I can go back and listen to that again. These are definitely words of wisdom. I love it, and it's interesting to, as I say, to learn from each other, and that's a big part of that active listening. To your point, one last question, Brittany. Before we conclude, I want to go back a little bit about the strength of the teamwork here. And you have a wonderful tumor board that you mentioned before with multiple team members. Tell me a little bit more for the audience how often you have this tumor board. How do you connect that review with the patient care in clinic?
Yeah, so our tumor board is fantastic, of course, because it's every week. It's every Wednesday at 4:30. Everybody gets together. We're very fortunate to have a very well fleshed out tumor board. Other places I've been, it's really just the surgeon saying, "Okay, we're going to do surgery. Okay, we're going to do surgery." Our tumor board is truly a multidisciplinary effort. It's the surgeons, it's the medical oncologists, radiation oncologists, the speech and language pathologists, the radiologists, the pathologists, and they're all on, and they all, will comment on cases. And we are fortunate to have such a high volume program. The most of what we're describing are 1 in 1,000 cases where there's no right answer, and so that's where the team is incredibly helpful. The way it often works for referring physicians as well is they can say, "Hey, can you review this at your tumor board and look at this imaging?" Or, "Hey, can you kind of discuss with the team and see if this is an appropriate candidate for this trial or that trial?" And I can give you the information, and then we can just get back to them so that it's not necessary for the patient to come 6 hours to see us just for us to tell them that. So it's a great opportunity for learning. It's a great opportunity for teamwork, for multidisciplinary discussion, and it's also a great opportunity to facilitate care across a very large region. So it's worked well many times to save people a lot of travel when possible, especially over the winter.
Absolutely. And, it's so interesting to see how the different disciplines come together and they're very synergistic and individualizing the knowledge in the particular patient in front of us. And I think this patient-centered approach makes it, unique and special, finding the right possible answer for this particular clinical question. And I think patients love that, right? Love this interaction.
Yeah, we'll often things that will come up in our tumor board, which I think is special about our tumor board, is this patient wants this. This is what they want. This is our recommendation based on guidelines. How can we make this happen, this desire happen? And that pertains to parts of surgery, reconstruction. And then in addition, in some scenarios, what clinical trial they would prefer, whether they want to try surgery or whether clinical trial is more in line with their goals of care. So it is truly one where the ultimate last kind of line in that tumor board discussion is the patient wants this, so we're going to think about this approach, or our recommendation will be this. And so I think it's the right way to deliver care.
Totally agree. And I think, this, I would say, plasticity or flexibility, taking into account the patient's needs and priorities and wishes at the same time, considering the best available evidence, the best available guidelines, and of course, clinical trials, and how we can learn through those important questions. Brittany, I have to say that I would love to talk to you forever, but time flies. I have to find a second reason to invite you to a second podcast. It's so great. Maybe a last quick question before we conclude here is you mentioned already that there is increase in the incidence of head and neck cancers until we find ways. Vaccination against HPV is one of those ways to reduce incidence. But you see the outcomes are getting better. Is that right? And you see that improvement down the road?
Yeah, certainly with HPV-related cancers, outcomes are improving as we de-escalate care. We're managing to de-escalate care and maintain those outcomes, and so that's been a passion of mine, again, a shared effort, I think, amongst our entire field of head neck oncology to make sure that we are able to safely de-escalate care for those patients and maintain those really excellent outcomes functionally and from a survival standpoint. The HPV negative cancers, that I think the improvements in that domain have been a little bit more modest, and they've primarily been, in my opinion, and from what the literature would suggest, they've primarily been as a result of multidisciplinary care, team care, cancer center care, care on a global scale for what can be a very aggressive cancer. So, the improvements have been modest, but mostly it related to just better overall care over the last 20 years. And there's a lot of data to suggest that. When it comes to other cancers, a lot of the other cancers that exist in the head and neck are surgical. And so, as surgical care has improved, um, patients have gotten sicker, but surgical care has improved, though the survival from those cancers has also improved. But, depending on which one you're talking about. So, overall, I think we are winning. We just have to continue to push the envelope, advance the field, continue to put everything we have into advancing precision oncology for cancer patients, and I think we'll continue to win.
Absolutely. And with this hopeful note that we have made so much progress, we're winning, we keep that success and we get inspired to win even more in the future. And I think with your inspiring research, the great teamwork and the talent here at Fred Hutch Cancer Center, we're hopeful for many more wins against head and neck cancers. We're looking towards a future with more cures, better outcomes, better function, and longer survival. So thank you, Brittany, for facilitating that effort and the improvement towards winning. And of course, thank you for your time today. Thanks so much to the audience. Feel free to like and subscribe. More surprises and more episodes are coming. Thank you so much. Have a great day.